Hi, this is Dr. Poole again, and we're going to talk about acute inflammation. In comparison with chronic inflammation, acute inflammation is rapid in onset and is usually of short duration. The key hallmarks are tissue edema and the presence of neutrophils. We'll talk about chronic inflammation in the next case. Inflammatory reactions can be triggered by a variety of stimuli. Infections, bacterial, viral, fungal, parasitic, and microbial toxins are among the most common and medically important causes of inflammation. Tissue necrosis elicits inflammation regardless of the cause of cell death, which may include ischemia, that is reduced blood flow, trauma, and physical and chemical injury, such as thermal injury, as in burns or frostbite. Several molecules released from necrotic cells are known to trigger inflammation. Foreign bodies, such as splinters or sutures, may elicit inflammation by themselves or because they cause traumatic tissue injury or carry microbes. Even some endogenous substances can be considered potentially harmful if large amounts are deposited in tissues, such as urate crystals in the disease gout, cholesterol crystals, as in atherosclerosis, and lipids in obesity-associated metabolic syndrome. Immune reactions, also called hypersensitivity, are reactions in which the normally protective immune system damages the individual's own tissues. The injurious immune responses may be directed against self-antigens, causing autoimmune diseases, or may be inappropriate reactions against environmental substances. The rest of this talk will focus on the hallmarks of acute inflammation, the vascular changes, and the cellular events, the morphologic patterns that we see with acute inflammation, and finally, the outcomes. Acute inflammation has three major components: dilation of small vessels leading to an increase in blood flow, increased permeability of the microvasculature, enabling plasma proteins and leukocytes to leave the circulation, and emigration of leukocytes from the microcirculation, their accumulation in the focus of injury, and their activation to eliminate the offending agent. The vascular reactions of acute inflammation consist of changes in the flow of blood and the permeability of vessels, both designed to maximize the movement of plasma proteins and leukocytes out of the circulation and into the site of infection or injury. Changes in vascular flow and caliber begin early after injury and consist of the following. Vasodilation is induced by the action of several mediators on vascular smooth muscle. It's one of the earliest manifestations of acute inflammation. Vasodilation first involves the arterioles and then leads to opening of new capillary beds in the area. The result of increased blood flow, which is seen clinically as heat and redness, is present at the site of inflammation. Vasodilation is quickly followed by increased permeability of the microvasculature, with the outpouring of protein-rich fluid into the extravascular tissues. This process we described in detail next. The loss of fluid and increased vessel diameter leads to slower blood flow, concentration of red cells in small vessels, and increased viscosity of the blood. These changes result in engorgement of small vessels with slowly moving red cells, a condition termed stasis, which is seen macroscopically as vascular congestion and again localized redness of the involved tissue. Increased permeability of postcapillary venules is another hallmark of acute inflammation that allows increased transport of fluids and proteins called transcytosis through the endothelial cell barrier. Contraction of endothelial cells resulting in increased spaces between endothelial cells is the most common mechanism of vascular leakage. It's elicited by histamine and other chemical mediators. This is called the immediate transient response because it occurs rapidly after exposure to the mediator and usually is short-lived, 15 to 30 minutes. In some forms of mild injury, such as after burns, irradiation, or UV radiation, and exposure to some bacterial toxins, vascular leakage begins after a delay of 2 to 12 hours and lasts for several hours or even days. This delayed prolonged leakage may be caused by contraction of endothelial cells or mild endothelial damage. Late appearing sunburn is a good example of this type of leakage. Endothelial injury resulting in endothelial cell necrosis and detachment. Direct damage to the endothelium is encountered in several injuries, for example in burns, or is induced by the actions of microbes and microbial toxins that target endothelial cells. These extravascular fluid accumulations have several different names, and this slide describes and defines these terms that you should be aware of. Edema refers to the general excess of fluid in the interstitium or accumulation in serosal cavities. A transudate is non-inflammatory and consists of an ultrafiltrate of plasma. It can be caused by osmotic or hydrostatic pressure imbalances. An exudate, on the other hand, is an inflammatory fluid. It contains increased proteins and white blood cells, and this is due to an alteration in normal vessel permeability. Pus is just a purulent exudate that is rich in leukocytes and necrotic cellular debris. This is a nice graphic that summarizes these concepts and displays the differences between an exudate and a transudate. The changes in blood flow and vascular permeability are quickly followed by an influx of leukocytes into the tissues. These leukocytes perform the key function of eliminating the offending agents. The most important leukocytes in typical inflammatory reactions are the ones capable of phagocytosis, namely neutrophils and macrophages. The downside is that when strongly activated, they may induce tissue damage and prolong inflammation because the leukocyte products that destroy microbes and help clean up necrotic tissues are nonspecific and can also injure normal bystander host tissues. Now, if you remember what Dr. John Hunter identified, again, inflammation is a stereotypic stepwise response to an inflammatory process. The journey of leukocytes from the vessel lumen to the tissue is a multi-step process that is mediated and controlled by adhesion molecules and cytokines called chemokines. This process can be divided then into sequential phases. In the lumen, margination, rolling, and adhesion to endothelium. Vascular endothelium in its normal unactivated state does not bind circulating cells or impede their passage. But in inflammation, the endothelium is activated and can bind leukocytes as a prelude to their exit from the blood vessels. In normally flowing blood and venules, red cells are confined to the central axial column, displacing the leukocytes to the wall of the vessel. Because blood flow slows down early in inflammation, remember stasis, hemodynamic conditions change, and more white cells assume a peripheral position along the endothelial surface. This process of leukocyte redistribution is called margination. Subsequently, leukocytes adhere transiently to the endothelium, detach and bind again, thus rolling along the vessel wall. The cells finally come to rest at some point where they adhere firmly. So take a look at the video that's included in the study guide from YouTube that gives you a graphical illustration of this process. The second step is migration across the endothelium and vessel wall. In this process, leukocyte recruitment is migration of the leukocytes through the endothelium, called transmigration or diapedesis. Transmigration of leukocytes occurs mainly in postcapillary venules. The third step is migration in the tissues toward a chemotactic stimulus. After exiting the circulation, leukocytes move in the tissues toward the site of injury by a process called chemotaxis, which is defined as locomotion along a chemical gradient. Both exogenous and endogenous substances can act as chemoattractants. The most common exogenous agents are bacterial products. Endogenous chemoattractants include several chemical mediators, such as cytokines, particularly those of the chemokine family, components of the complement system, particularly C5a, and arachidonic acid metabolites, mainly leukotriene B4. This is just another graphical illustration of what I just outlined in the previous slide. The details of the different chemical receptors and so forth, please, that's covered more in pathophysiology, but I couldn't eliminate it from the slide very easily. So just imagine the leukocytes tumbling along the endothelial surface until they finally adhere and then transmigrate through the endothelium and then go to the site of inflammation through chemotaxis. I think the video will illustrate this even better. This is a nice graphic that illustrates the sequential steps then in phagocytosis. Phagocytosis involves 3 sequential steps, including recognition and attachment of the particle to be ingested by the leukocyte, engulfment with subsequent formation of a phagocytic vacuole, and finally killing or degradation of the ingested material. Okay, this graphic illustrates the nature of the different leukocyte infiltrates in inflammatory reactions. The panel to the left shows myocardium after ischemic necrosis or infarction. Early in this process, the inflammatory infiltrate is dominated by neutrophils and congested blood vessels. The green arrow points at a neutrophil in the tissue. Later, mononuclear cellular infiltrates dominate the inflammatory reaction, and the blue arrow is pointing at a lymphocyte. Finally, the right panel shows the approximate kinetics of edema and cellular infiltration, comparing acute inflammation, which is to the left, to chronic inflammation, which begins to dominate after 2 or 3 days. So keep that in mind as we complete our survey of acute inflammation, and for the next case when I talk about chronic inflammation. Okay, finally I can show you some real pathology now. There's several different morphologic patterns of acute inflammation: serous inflammation, fibrinous inflammation, purulent or suppurative inflammation, and finally ulcers. So let's take each one of these, and I'll show you examples of each of these. Serous inflammation is marked by the exudation of cell pore fluid into spaces created by cell injury or into body cavities, such as the peritoneum, pleura, or pericardium. Typically, the fluid in serous inflammation is not infected by destructive organisms and does not contain large numbers of leukocytes. In body cavities, the fluid may be derived from the plasma as a result of increased vascular permeability or from the secretions of mesothelial cells. These are the cells lining body cavities. Accumulation of fluid in these cavities is called an effusion. This is a microscopic image of skin. In a common situation that I'm sure most of us have experienced, a skin blister. And this shows the superficial layer called the epidermis separated from the underlying connective tissue called the dermis by a focal collection of serous effusion, which is indicated by the arrows. Note that in this image, this space is clear mainly because it consists predominantly of cell pore fluid, and those small dots in there are the relatively few inflammatory cells that are present in this fluid. For some reason, you gentle students have some difficulty with fibrinous inflammation. So I'll try to explain this in a little bit more detail. With greater increases in vascular permeability, large molecules such as fibrinogen pass out of the blood, and fibrin is formed from fibrinogen and deposited in the extracellular space. A fibrinous exudate develops when the vascular leaks are large, or there is a local procoagulant stimulus. The conversion of fibrinogen to fibrin is an integral part of coagulation, and I think the difficulty that students have sometimes is that we don't really discuss these together. A fibrinous exudate is characteristic of inflammation in the lining of body cavities, such as the meninges, pericardium, and pleura. Now, histologically, fibrin appears as an eosinophilic, that is bright pink, meshwork of threads, or sometimes as amorphous material. This is a classic site for fibrinous inflammation, the pericardium. In the center of this image is the heart, and this clamp is reflecting back the pericardium, which is the layer that envelops the heart. And you can see on the surface it has a granular, roughened appearance, and that's because of deposition of fibrin on the pericardial surfaces. Microscopically, what we see in the right panel is a pink meshwork of fibrin exudate, indicated by the letter F, which overlies the pericardial surface, which is to the left, and indicated by P. We'll learn a lot more about this in the vital gases to fluid, vital gases and fluids course, but for right now, this is just an image illustrating this morphologic pattern of acute inflammation. Purulent inflammation is what one usually thinks about with acute inflammation, and is characterized by the production of pus, an exudate consisting of neutrophils, the liquefied debris of necrotic cells, and edema fluid. The most frequent cause of purulent or suppurative inflammation is infection with bacteria that cause liquefactive tissue necrosis, such as staphylococci. These are also referred to as pyogenic, that is, pus-producing bacteria. A common example of acute suppurative inflammation is acute appendicitis. Abscesses are just localized collections of purulent inflammation that are caused by suppuration, buried in a tissue, an organ, or a confined space. And this image illustrates purulent inflammation. To the left, the multiple tan, slightly raised lesions indicated by the arrows is lung in a case of bronchopneumonia. Microscopically, the abscesses contain numerous neutrophils and necrotic cellular debris, and is surrounded by congested blood vessels. So here's the collection of neutrophils and necrotic debris, and these bright red areas are the congested blood vessels. An ulcer is a local defect or excavation of the surface of an organ or tissue that is produced by sloughing or shedding of inflamed necrotic tissue. Ulceration can occur only when tissue necrosis and resultant inflammation exist on or near a surface. It's most commonly encountered then in the mucosa of the mouth, stomach, intestines, or genitourinary tracts, and in the skin and subcutaneous tissue. During the acute stage, there's an intense neutrophilic infiltration and vascular dilation in the margins of the defect. As this becomes more chronic, the margins and the base of the ulcer develop fibroblastic proliferation, scarring or fibrosis, and the accumulation of chronic inflammatory cells including lymphocytes, plasma cells, and macrophages. This image is from the first part of the small bowel called the duodenum and is a chronic duodenal ulcer. To the right is a microscopic image of a duodenal ulcer crater which has an acute inflammatory exudate at the base indicated by the blue arrow. Finally, I'll talk about the outcomes of acute inflammation. First is complete resolution. In a perfect world, all inflammatory reactions should end with restoration of the site of acute inflammation to normal. This is called resolution and is the usual outcome when the injury is limited or short-lived, or when there has been little tissue destruction and the damaged parenchymal cells have the capacity of regeneration. Scarring or fibrosis is healing by connective tissue replacement. This occurs after substantial tissue destruction when the inflammatory injury involves tissues that are incapable of regeneration, or when there is abundant fibrin exudation in tissue or in serous cavities that cannot be adequately cleared. In all these situations, connective tissue grows into the area of damage or exudate, converting it into a mass of fibrous tissue, a process that we call organization. The final outcome is chronic inflammation. Acute to chronic transition occurs when the acute inflammatory response cannot be resolved as a result of either the persistence of the injurious agent or some interference with the normal process of healing. This image for you to study is just a graphic illustration of what I just talked about, the outcomes of acute inflammation: resolution, healing by fibrosis, or chronic inflammation. Okay, let me summarize what you've learned about in this presentation. Acute inflammation has several hallmarks, which are a sequence of vascular changes and cellular events. It's the vascular and cellular reactions that account for the signs and symptoms of the inflammatory response. Redness, warmth, swelling are caused by increased blood flow and edema. Pain is caused by release of chemical mediators during inflammation and damage. You learned about 4 morphologic patterns of acute inflammation: serous inflammation, fibrinous inflammation, purulent inflammation, and ulcers. You learned about 3 outcomes of acute inflammation: resolution, fibrosis, and chronic inflammation, which we'll learn a lot more about in the next case. Thanks.